Hey, gang, it is Wednesday, almost the end of the week. So excited, getting close to Hanukkah, Christmas, all that fun stuff. Welcome to Dentist in the Know. This is your backstage pass for current trends, politics, and education in the dental world. It is live, and as always, it is over something to make us forget about the earlier part of the week. Tonight, that happens to be from the Hess collection. Drinking a little Alomi Cabernet Sauvignon. So I got that going for me, making my week a little bit better, which it definitely needs to be. Anyway, as I said, this is Dentist in the Know Humpday Happy Hour. We're excited to have you. As you know, we are always here together. I'm here with my best friends, Dr. Chad Duplantis and Dr. Jennifer Bell. We are all practicing dentists. We are all educators, and we are all business owners. And guess what our job is? Our job is to bring all of you in the know. Tonight's show is brought to you by some very special friends of ours at DentalRay. Lots of talk about this in the past couple of weeks. Everyone's been talking about, what do I do with my CBCT diagnosis? What should I be afraid of? What should I be looking for? We're going to answer all those questions for you tonight. This is a great, great program we have in store for you. So anyway, welcome to Humpday Happy Hour. I have a feeling that with our guests tonight, that we are going to have so much to talk about. They have some presentation slides for us. It's a bunch of guys that couldn't get into dental school, guys and gals, so they decided to become neuroradiologists or some kind of hack job like that. I don't know. Whatever. They did something cool with it anyway. I'm going to tell you that. And this is technology all of you are going to want to know about. All of you need to understand and implement in your practices, because all of us have been so touched by this technology in our practices, and all three of us use it, and all three of us absolutely sing the praises of DentalRay. So with that said, I want to cut it short so we leave enough time for our guests. JB, do you have any news?
Just a few quick items, guys. We won't stay long. So, we've been talking about, we'll go back to November when the Massachusetts question 2 on their ballot came up about medical loss ratio. I did a whole news segment on what that means. So we won't spend time today. We'll reference that back. But it did pass. And the whole intent and purpose of that particular ballot issue was to ensure that insurance companies were using their revenues towards patients and services that are being provided to patients and reimbursements back to providers. So it's the 80-20 rule, or 83 and change. There's been different ratios that have been thrown out there, but ultimately ensuring that insurance companies are putting their dollars back into patient care and provider reimbursements as opposed to other avenues. So when that passed, and certainly there have been a few other laws that had passed prior to that in other states, Massachusetts seemed to have gotten the most attention for this particular issue. And so recently the ADA polled dentists again, as they do regularly. And we've talked about that a lot on this podcast, about how we're trying to collect all that data to really understand on a grassroots level what's happening with dentists in their dental offices every day. And the recent study that came out from that, or collection of data that came out from that survey, was that 8 out of 10 dentists believe that insurance reform is a top issue moving into 23. So I think the Massachusetts question 2 was a real, pot stirrer, if you will, to bring a lot of attention to the fact that there are many insurance companies that are not complying with this particular ratio set, and that maybe all of the premium dollars coming in aren't being redirected back into patient care and provider reimbursement. Just this week, Nevada has put forward their version of question 2 for Massachusetts with similar language, looking at 83% for their medical loss ratio threshold. So I think we're going to see a lot more states starting to look at this. It was very similar when we were looking at non-reimbursed service coverage and whether or not insurances could dictate what dentists could charge if the service wasn't covered or reimbursed by the insurance companies. 38 states took that up and passed legislation to protect providers. It looks like we may be at the precipice of the same snowball reaction from question 2 in Massachusetts and the medical loss ratio. In dear sympathy to Jeff's current plight of losing one of his medical providers now out for a hip replacement, JADA just put out this week a new study relating to antibiotic prophylaxis for joint replacement. Of course, we're going to have to get the orthopedic surgeons on board to really look at the data and determine whether or not this overabundance of prescribing. Yes, I'm going to have an opinion on this. I rarely do that in the news, but the overabundance of orthopedic surgeons wanting patients to be on antibiotics for life to protect a joint replacement. There's a lot more data coming out to say that that is not actually very protective and or required for those joint replacements. So we'll spend a little bit more time on that next week. We have a great show lined up for that, but we want to make sure we give plenty of time and attention to our topic at hand tonight. The last thing I'll mention is if you haven't voted for the Cuspies yet, we're up for Dental Influencer of the Year. We're really pumped about it, getting a lot of great text messages and notes being sent that people are voting for us. And I can't tell you how humbling that is to even be nominated or recognized on this spectrum, but then to have colleagues, friends, educational partners participating in perhaps being recognized as Dental Influencer of the Year has been really great. So if you haven't voted yet, drbycuspid.com, click on the Cuspies. You'll see us listed under the Dental Influencers of the Year category. Plenty of other categories, I think 14 in total, that you can voice your opinion about and direct the future of content for 2023. With that, guys, I'll turn it back over to you.
You know, I don't know where Jeff went. There he is. I think that's fantastic that you brought all that stuff up. You know, we got Massachusetts, we got the orthopedic surgeons, we got the Cuspies, but I want to zone in on the orthopedic surgeons for just a second because literally I just about posted that today on Dentist in the Know because I'm getting sick and tired of the misinformation, disinformation, lack of concern, lack of care. You know, you've got surgeons that demand it for life, but they refuse to prescribe it. You've got surgeons that say it's not necessary at all. You got the ADA that in 2012 said it's not necessary at all. And so really, when a surgeon says, I don't care, we go by the ADA. Otherwise, I leave it up to the surgeon because I've had a patient lose a knee because of something that was blamed on me. And I just don't want to get into it anymore, but I wish there was a sound statement and an agreement. And it's time that we as dentists start getting together with these orthopedic surgeons, with these cardiologists, and really talk about pre-medication and figure out where it goes, what it needs to be, and come up with a conclusion and be consistent.
Yeah. Functional medicine, those two words. I mean, we're seeing a whole new breed of physicians now that are saying, hey, we need to be working with all of our other colleagues in medicine and looking at the body as a whole, as opposed to just narrowing our spectrum to the small area of focus that we stay in. And so that's a great point, Chad. And you saw how much I didn't expect when I put the post up about antibiotic coverage, and my associate who's now in the hospital with his wife having a baby with some other medical concerns. But when I posted that about him being so upset that he thought he was doing everything according to the ADA, then this lady ends up in the hospital, and what was the other end of that? You overprescribe and they end up in the hospital with C. diff. We're really between a rock and a hard place, when we have guidelines and legally yes, will probably be okay, but that doesn't stop the hassles of people still saying, why didn't you do it? Or, going to see the lawyer or filing a complaint with the state dental board. So it's really a tough area right now.
Well, and
It
as
really is.
clinicians, we carry those burdens. I know everybody wants to criminalize this, but we do carry those burdens very heavily.
Yeah.
We didn't go into this to hurt people. We went into this to help people. And if you think in any way a decision that you made, those are the things that keep you up at night. That's the stuff that you think about when you put your head on a pillow. Did I make the right decision? Did I do the right thing for that patient? Did they think less of me? Did I let them down in some way as a clinician? Yeah. So despite the legal piece, we carry those emotional burdens and mental burdens, I think, as well.
Yeah. Well, great conversation. And thank you for mentioning, I'm so excited about our nominations. It's very humbling, and it's, aside from all the money that we're making from doing this and the mailman saying, look, Jeff, another empty mailbox. Aside from that, no, it's just that is really what makes it worth it to us. The fact that you guys appreciate what we're doing and trying to bring you great information. So thank you. We appreciate the nominations. We appreciate your votes for sure. And we just appreciate you hanging out with us and having a glass of wine on Wednesday too. So with that said, we have some really incredible people waiting in the wings here. Chad, JB, and myself, we've met them all. They are some of the smartest and some of the nicest people I've ever met in my life. And they have really revolutionized diagnostics, as far as I'm concerned, in our profession, at least. And I'm sure for many other professions, as we see CBCT technology kind of creep into other disciplines of medicine. So Chad, why don't you introduce our guests and let's get the ball rolling.
Yeah, that sounds like a great idea, Jeff. So back in September, we had the honor and privilege of visiting DentalRay. And for those of you that don't know what DentalRay is, you're going to learn a little bit more about that tonight. But, I just want to reflect a little bit upon my journey into dentistry. I started off my journey and I wanted to become a neuroradiologist. And at that point in time, I was like, you know what? I was like, screw that. I'm going to do something that's way better. I'm going to become a dentist. And, quite honestly, I could have gotten into neuroradiology with flying colors, but I decided to go to dentistry instead. And so what we did is we kind of sought out, we wanted to see who's actually reading these CBCTs. So we found a couple people with educational backgrounds. Dr. Jacob Brown, he went to Georgetown, which is okay, Yeah. Dr. Akshita Mehta.
It's no university of the Caribbean, I'll tell you that.
Dr. Akshita Mehta, she went to George Washington University. Once again, okay. And then after that, Dr. Jacob Brown, he went to UCSF for a training in neuroradiology, whatever the heck that is. And then, Dr. Akshita Mehta, she went to UT Southwestern, which I have a lot of pride for, and I'll give her credit because that is in Dallas-Fort Worth, Texas. But regardless, all kidding aside, these are two fascinating people that are way out of my league. They could have gotten into dental school probably the first round. But they decided to go into neuroradiology. So let's, without further ado, introduce our good friend, Dr. Jacob Brown, and our new friend, Dr. Akshita Mehta. So thank you all so much for being here.
Hey, guys.
Yeah.
Welcome.
Hello. Really horrible accolades you have there. Sorry, it is what it is. So.
Hey, I have to tell a really quick story, though. So my son is right now in the process of applying to medical schools. Just got into his first school, and they actually called him back because they gave him like a 3-week window to accept. And they said, and just so you know, we understand your father's a doctor or dentist, excuse me. We understand your father's a dentist, but that doesn't really count. So you're going to be eligible for for the first, it's something like the first doctor in the family, some kind of scholarship.
Yeah.
But we understand your
dad-
dad's a dentist,
sorry,
but that
your
doesn't
dad's
really
just
count.
a
So you're going to
dentist.
be eligible. I'm like, you know what? You can call me just a dentist all day long. Give me the money.
Yeah.
Hey, that makes you eligible for a scholarship.
First
amazing.
position in the family scholarship of some
There
type.
you go.
That's great. That's
Wow.
great.
Oh,
Wow.
such a pleasure to be here with you guys. Congratulations on the nomination. Wow.
Oh,
Thank
thanks.
you.
Well deserved.
Thank
I've already laughed and I've been informed. I've been entertained. I love it.
What else could you ask for?
And
Yeah.
it didn't even go south when it should have gone south,
And
which
it was-
typically it would.
It was teetering.
We only didn't do it because there were neuroradiologists on the show tonight.
Yes.
Oh,
So-
boy. Oh, boy.
You know, I'm gonna start with Dr. Mehta. I want to ask you a question, and then I'm gonna ask Dr. Brown the same question, and then I want to go over some of our answers from yesterday, if that's okay with both of you all. So we'll all pull up the post from yesterday. But what made you decide to go into neuroradiology?
Oh, good question. Well, true story. I was actually pre-dental in undergrad.
Knew it. I
Yes!
told you. You looked like it.
True story. And I was like, gosh, you know what? This just looks hard. I think I'm just gonna go to med
That
school.
was
You're
it.
so full
Yeah.
of crap.
Yeah.
But we love it.
Yeah. So that's the story behind that one. And then neuro, I went into radiology because I love the visual aspect of it. I love just looking at pathology. A lot of it made sense. You can see it. Huge impact on care. That's just very tangible that I loved. And neuro has always been an area of interest. So I read head and neck imaging. I read brain imaging. I read spine imaging. I love the pathology that comes with it. I love our referring clinicians that we deal with day in and day out. And it's just a little bit of everything and incredibly complex anatomy, like you guys are very well aware. And like we'll talk about a little bit, but yeah, the complexity, the anatomy, the wide range of pathology that we see, absolutely love it.
Love it. Jacob, what's your answer?
Yeah, honestly, for me, it gets to it's really the decision point for a lot of future treatment for the patient. So they come into the emergency department, or they're at your office getting a CT scan, and that is the decision point where we get to the heart of a diagnosis a lot of times with the clinical information that's coming in, and then is this a stroke? Is this a brain abscess? Is this an expansile lesion of the mandible? So that being at that point where you're affecting patient care in that moment is what attracted me to neuroradiology and head and neck imaging.
So
Awesome.
let me jump in here because I want to make sure for everyone that's going to watch this eventually, before we get too deep into this, Jacob, you are a co-founder of DentalRay, is that correct? And so tell us, what was the impetus for that, and then maybe give us a quick overview of what DentalRay is. They've heard us talk about it, but I want them to hear you speak about it from the founder's perspective and the need that you saw.
Yeah, absolutely. So do I get a scholarship in my family? So I'm my dad is an orthodontist and my brother's an orthodontist and all my cousins are dentists. So maybe that gives me a scholarship for being.
Did you get a scholarship?
You should have.
Right? I should have.
Yeah.
Really climbing out of that trench, of dentists to better yourself.
It's not a full ride. Don't worry.
I love the dental field and my dental colleagues and when I've kind of been sitting kind of oblivious, surrounded by a radiology department with like millions of dollars of scanners and the helical donut shaped scanners that we're all familiar with. And I've been oblivious, I'll tell you the truth, to the quality and the level of imaging that's being offered at the point of care in your dental clinics. And I've kind of had the viewpoint that I'm just going to sit back and wait for patients to come to me. They have to go jump through a bunch of hoops, get an appointment, come to the scanner, and then I'm going to be there looking at their CT images on the other side. And now I have like my brother and my cousins, they're coming to me and they're saying, hey, we're doing CT imaging in our office. And I said, what? And so they started showing me these, this was several years ago, but they're showing me these scans and they're showing me the images that they're taking in their office. And I have to say that I was blown away by the quality of imaging and the ability you guys have to diagnose and affect patient care at the point of care. So it's not patients like going through, months of getting referred for additional appointments and going to an outpatient imaging center or a hospital and potentially paying, 10x the price for their imaging study. And they said, I had my family members say to me, we're getting these images in our offices, and honestly, we're starting to see some things here that we're not really familiar with, or maybe we don't feel as comfortable evaluating for ourselves. And they asked, hey, is this where radiologists could potentially help us? And that's where DentalRay was born. I have tremendous friends and colleagues and co-founders who have created this incredible, technically proficient product that allows scans to automatically be sent from a dental office to an interpreting radiologist. So that all happens totally seamlessly, just like it would in the medical imaging space where we're sitting in a hospital, and every time that a physician or a doctor ordered a study, it gets sent automatically to a radiologist for an interpretation. So that's just a really brief history of DentalRay and the founding and why it's so critical for me.
And just as a quick follow-up, I would ask, what is it that you think scares most dentists or most non-physicians, I should say, about having this kind of technology in their office? I know from our end, people say, well, I'm afraid to take a large field of view CBCT because I'm afraid I'm going to be responsible for everything on that scan. And we hear that all the time. So, how much does that play into what you decided to do? And then what was your strategy based on that?
Yeah, absolutely. So my brother is an example of that. He's very, he's conservative and risk conscious. And so he'll purposely take a very, very small field of view with his cone beam CT scanner, or he was purposely taking a small field of view with his cone beam CT scanner because he didn't want to have that exposure, because he we're dealing with, as Dr. Mehta referred to, this is, probably the most complex anatomic region in the body. And so he's aware that when he starts imaging outside of the dentition, when you start getting into the skull base and the cervical spine and the nasopharynx and the perinasal sinuses, that it wasn't an area that he was, comfortable evaluating. But then it does take this technology and this incredible imaging technology that you have at the point of care, and it kind of constrains it, because then, if we potentially expanded the field of view to identify additional areas of pathology or potential reasons that the patient might be there in your office, we can get to, in a lot of cases, a more complete, comprehensive picture of what's going on with the patient. So I think that's one of the main concerns that people have when they're using cone beam CT in their office. And we want to be their imaging partner, so that, you don't have, my brother now, he doesn't take a cone beam CT without having me look at it, right? So, he doesn't have to think, did I really look at this adequately in between patients? Do I need to stay for a half an hour to look at these scans before I go home? We are his imaging partner, and there's radiologists that are just seamlessly, receiving these studies and then sending a report back to his dashboard so that he can view those.
Do you charge him? I'm sorry, Jacob. I had to ask. It was a joke.
I got to get even some way. In this dental school, medical school battle, I had to get even. Hey, my brother takes a 2-hour lunch every day. And what do I get? I'm eating a sandwich at my workstation. So I gotta extract that back from him, right?
Yeah, exactly. I would. Extract's a good word too.
I think as you go through your slides tonight, Jacob, I just want to give my own testimony. I was that doctor who showed up at DentalRay taking a small field because I didn't want to be liable. What you don't realize is even in a small field, you're still getting a three-dimensional scope of things that you don't know anything about. And I think your content is very powerful in the very minutia of the things that you would see, I would never pick up on. And we pride ourselves as dentists of being early detectors. You know, we pre-screen hypertension because we often see patients more frequently than the primary care physician. So we pre-screen for that. We pre-screen for diabetes if we feel inclined. We look for oral cancers and all the things that are impactful to patients, and we hope to find those things early. And yet there is the slight possibility that if you're taking a CBCT, you've missed pathology, not of, you know, maleficence or whatever, but just simply because you didn't know any better or couldn't see it. So for me, that's my testimony of DentalRay, and to say that, you know, you don't know what you don't know, but once your eyes are open, as Coy says, you have no excuse but to do better. And so I know that will be the impact of the content that you're going to share tonight. And I can't wait to see it all and digest it.
So I'm going to go ahead and pull the, I'm going to go ahead and put the PowerPoint up for all
Let
of you.
Jacob do that, Jeff, so that he has control over it, if you don't mind.
Is he able to do that? Do you have the add to stream?
Yes.
And while you're pulling that up, I'll give you a second to get that set up. I'll piggyback on what JB said, because I'm actually a little bit of the opposite. I'm the guy that's had CBC technology in my practice for the last almost 15 years. So anybody who's heard me speak say that I could never have branched out into airway and TMJ and the level of orthodontics that we're doing in full mouth rehabilitation without larger fields of view to give me all of the information that I need. I need to see the TMD, and I need to see the airway, and I need to see the cervical spine, and I need to see the teeth, and I need to see the skeletal pattern. I need all of these things, but with that comes a lot of other anatomy. And so that's kind of the gray area. But I've always felt like, well, I would rather do my best job and not be held responsible for things that a dentist wouldn't be expected to know. But now I don't have to worry about that, because all of those extraneous structures that are outside of my scope of practice are automatically read by you guys. So that totally took that away. And I'm a big advocate of large field of view for comprehensive diagnosis. If you're really trying to be a comprehensive diagnostician and do, you know, really treat people as opposed to just teeth, I think we need all these structures, but we need people like you to help us with all the structures that surround them. So I'll leave it to you to go ahead and present.
And before he presents, I do have a question for Akshita, because I think that this would be really good coming from her. Jacob's the chief medical officer for DentalRay, but Akshita, you actually do a lot of the reading of the images. We had talked about this when we were in Salt Lake City. Tell us a little bit, while Jacob's bringing this up, about the template that you all have gathered to read these images. Would you mind doing so?
Yeah, absolutely. So the template is, again, just an aid for everything that we're talking about here. It goes through all of that extra anatomy that Jacob and I look at every single day. We look at the skull base, we look at the temporomandibular joints, we look at all of the osseous anatomy within the face, we look at the soft tissues, we look at the salivary glands that we can visualize, the nasopharyngeal structures, and we put that in what we hope is a very easy to read template laid out by anatomy in a systematic approach that we use in our daily practice. So that is a very thorough way that we can look at all this, make sure that we're not missing anything, make sure we're looking at everything and being as safe as possible for our patients. And a lot of this alludes to what Dr. Bell was talking about before. You know, we're all here to do the best that we can for the patients. That's always our main goal. And it really is that, you know, end of the day, when you put your head down, how do you feel? and that emotional piece to it, the mental piece to it. And we're doing cone beam CTs because it is the right thing for the patient. There's a lot of beneficial information we get, but some of that extraneous anatomy is, maybe not part of the everyday wheelhouse. But Jacob and I, we read maxillofacial CTs every single day. And so this is just such a cool collaboration on our part to be able to do this for more patients than we otherwise would have.
That's awesome. That's awesome.
Yeah, I love that, Akshita, we've joked a little bit about dental school and medical school, and at the end of the day, I mean, when we went to our dental school or our medical school interviews, we probably said something pretty similar when people said, "Why do you want to do this?" And that was, I want to help people, and I hope we still feel that way. And I think your discussion earlier about prophylactic antibiotics brings up, it highlights what we're trying to do with DentalRay, which is kind of break down this wall between this is like some arbitrary dental issue, and then this is a medical issue over here, and there's some just kind of artificial construct in between those things, and take a more interdisciplinary approach to taking better care of our patients. Yeah, I'm happy to share this if you are you able to see that slide, or?
No, we're not. Before I put you in the stream, do you want me to? There it is.
Do you have control over it? Yes, you do. Okay.
Can you guys still see my mouse cursor?
No.
Do not see the mouse cursor, but your screen is up and we're all next to you.
Now we can. Now we can see your.
There it is.
We're good.
Okay, I'm going to leave it like this so you can see my my cursor.
I got you. Yeah, absolutely.
But yeah, I mean, this slide just says what we're about, right? It's dentists and physicians and trying to take care of, as we're just talking about, trying to take care of our patients in the best way we can. So DentalRay is that platform that connects dentists with physician radiologists, and I'm very glad that we've kind of brought this up already here today, but this is. Can you guys just give me a thumbs up that you can see these images?
Yes, we can.
Thanks. This is a cone beam CT from one of our referring doctors, and this is this would be a medium to large field of view, and I cringe a little bit when people refer to as a cone beam CT scan as just a dental scan. And I did some very rudimentary calculations here to just kind of illustrate that point. So this is the sagittal view, right, of this cone beam CT. And I just calculated the volume of these two spheres. So if we were saying that this is only a dental scan and that we're doing this to only evaluate the dentition, we'd be looking at 6% of the scan. And there's 94% of other things that we've referenced here already that are also within the field of view. And like we've said, this is a high rent area of the body, and a lot of bad things can happen in these areas.
So let's just break this down real quick. Some dentists will think that they're only responsible for 6% of that image, whereas in reality, we're responsible for the other 94 as well.
Yeah, so I mean, I think that gets to, as Akshita mentioned earlier, a radiologist is what we are trained for, and it took me a long time to become a neuroradiologist because I think I'm a slow learner. Akshita probably did it faster, but the reason why that training takes so long in part is because you're learning a search pattern, and you learn to go through every study exactly the same way every time. So you're doing a comprehensive analysis, and in every anatomic subsite you have in your mind, what are the 3 or 4 most common pathologies that I've seen in the last month, as I'm looking at studies from dental offices, hospitals, emergency departments, and you're doing a little checklist through in your mind as you go through the scan. So we approach every study as taking ownership of every slice of every CT scan. Akshita, what do you have any other comments on that? I know it's something that we do.
No, that's 100% right. And there's so much thought that goes behind every single image that we look at. Just the sagittal, right? What are we looking at here? There's the sella. Is there a macroadenoma there? Is there a suprasellar mass? Is there anything that's compressing on the ectochiasm? We see the clivus. Is there a mass there? Is that a med? Could there be a chordoma there, right? We're seeing part of the brain. Is there a Chiari? Is there any herniation there? Is there any tonsillar ectopia? We see the upper part of the cervical spine. Is there any, significant compression there that needs to be reported? Is there retroodontoid pannus that could be compressing that's, soft tissue and not even osseous? That could be difficult to see. There's so much anatomy that we're looking at, just on this one single image that's part of a huge cone beam CT. And as Jacob's saying, that's how we're trained to look at these things. Every single piece of anatomy, what happens there, in the brain? Is anything shifted at all? Could there be a mass even not on this image, but somewhere else in the brain that's causing some shift, causing the anatomy to look distorted, that then we should get follow-up brain imaging for to see why it looks like that. So going through, every single piece of anatomy that you can see what happens there, is this normal or abnormal, right? Is the first question. And there's such a huge variation of that, yeah, being responsible for 100% of this image is why it takes so long, and what we spend a long time trying to figure out.
You took the words right out of my mouth.
Yeah.
I mean, there were a lot of things there.
He has to go look up all of them.
Think about every single time, and I'm so thankful that I have you.
Hey, I have a quick question. When dentists take radiographs, we often already know the chief complaint, and we sort of have some precursor and often biased information that's affecting our view. Do you as radiologists like to know the chief complaint when you're reviewing that, or do you like to review first and then go back and correlate with the chief complaint?
Yeah, it can definitely happen both ways, but that's actually something that we I know that our development team and Derek, who you guys have met, is working hard on that right now, so that we can enable more dialogue because we want there to be a connection between our dental colleagues and physician radiologists. So we are building that in right now, so that we can, if you have additional information that would be helpful for us to make an interpretation, we would love to get that. It doesn't mean, what I reference in this slide is satisfaction of search, right? So it doesn't mean that we're going to just home in. If you say right maxillary pain and I find a small periapical lucency of the molar, I'm gonna tell you about that, and you can see that just as well as I can, of course, right? But that doesn't mean that I'm going to then. There's the potential, especially if you're busy in your clinic and you're trying to fit in your review of this scan before you get to the next patient. You're backed up and you're behind. There's the potential to just be satisfied that you found a problem that you think explains why the patient's there, and not review the rest of the scan. And that's how we would approach a study. Is we'll give you the answer and what we think is causing the pain, but we're going to check every corner of every slice of that scan for you.
Right.
Yeah, and just to piggyback off of what Jacob's saying. So, the way that we're trained, what a bunch of my attendings have said is, they'll ask us, well, what's the hardest thing to find? And it's the second finding, right? And what's even harder than that? And it's the third finding. When you find something that identifies or explains patient's symptoms, it's really easy to move on and say they have maxillary pain. Well, we see this periapical, lucency, that's it. And then close study. And then you don't find the thing that's in the corner that maybe they don't have symptoms of, but they will soon. Yeah.
So guys, why don't you go ahead and I want you guys to get through this, and we'll bring you back and do another presentation if we need to do a good, we could probably talk about this for 2 hours. So honestly, I love to nerd out on this.
We'd be happy to, but this just calls attention to my amazing colleagues. I couldn't be more proud of the group of radiologists that we have assembled to interpret these CT scans for our dental colleagues. And just to give you a sense for the training that goes into becoming a radiologist, it's the 4 years of medical school, 5 years of diagnostic radiology residency. And then most of our radiologists have completed 1 or 2 additional years in neuroradiology and craniofacial imaging. And like Akshita referenced, this is what we do all day, every day. And a typical radiologist reads over 10,000 studies per year. It's really important for DentalRay for our radiologists to be fully state licensed in the same state where they're interpreting studies. And that gets back to taking ownership, right? When we look at a study, we look at it as if we were the only people that were going to look at that CT scan. And so we want to be able to take ownership for you. This is really exciting for me, and gets to, what we've been referencing, right? These are some data that we're just preparing now for publication, but I ask our radiologists when they're reading a study to identify whether there's any unexpected or incidental finding that could potentially affect a patient's outcome if it wasn't identified. And when I went back and looked at the last 1,300 studies 1,200 plus studies that we interpreted, it was 1 out of every 13 patients that had an abnormality identified that could have resulted in an adverse patient outcome if it didn't receive follow-up or referral. And that this gives you an example of what this gets back to the fact that, is this a dental scan? Yes, it is a dental scan. We want to be there for you for the significant dental findings. But when we look at these findings that our radiologists are identifying, only 17% of them are in the area of the dentition, and 83% of them are coming from all the rest of the study. It's as you would expect, right? When we've discussed the larger field of view that's being obtained in a lot of these cases. And just to go forward one more here, I'll just show you kind of the breakdown for these incidental findings. So this just gives you a sense for the types of pathologies that our radiologists are identifying. And again, these aren't studies that come from the hospital or from some pre-selected group of high-risk patients. These are patients that came from your offices, and literally from your offices and the rest of our referring doctors. And I'll just call out a couple here. Paranasal sinus findings, 37 out of these 1,200 studies. Suspected mass, 26 out of these 1,252 studies. TMJ, orbits, inner ear. We've had some of our radiologists diagnose a very difficult to find kind of inner ear disorder called superior semicircular canal dehiscence. And I know that can be an extremely frustrating diagnosis. That it gets back to that you all have the ability to affect care while the patient is there in your clinic. The superior semicircular canal dehiscence is a diagnosis that can lead to them being referred to an otolaryngologist, then a neurologist, then getting an MRI, and then getting a hospital-based CT scan before you get to the right diagnosis of what's happening with this patient. So to me, this is totally astounding. We'll just go through one. Well, I have several here, but we'll just go through as time allows a couple of cases that just kind of illustrate some of these things that we're finding. So in this case, I'm just going to give a very brief history that this is jaw pain, and just want to emphasize that Akshita and I are very one of the things that a radiologist will do is look at the study in multiple planes, but then also apply different what we call windows to accentuate different areas of the study, different tissue contrast. So the way that a cone beam CT comes off in a dental scan is with this what we call a bone window, right? Where we emphasize the difference between cortical and trabecular bone, more dense cortical layer, obviously. But it doesn't show us the soft tissues very well. So if you look at the study, maybe you're looking at these dental restorations, you're looking at a little bit of mild maxillary sinus, mucosal thickening. But when you apply this soft tissue window, it's much easier to see this submandibular lymphadenopathy. So this is a coronal view, and this is an axial view, where you can see these very abnormally rounded submandibular lymph nodes.
So Jacob, I have a question. Is this software that you all have that alters the images that we send, or is this something within the software that we have access to as well?
Yes. It can be both, Chad. So most viewing modules will include a tool to adjust the window and level. What I've noticed when I've looked at the software that's bundled with cone beam CT scanners is that it's in a slider up at the top, and you have to slide one way and one the other way. And the way that our viewing software works more like what a radiologist is used to, where you can apply these presets to adjust the window and level, and you can also adjust it very quickly. Again, this is just as routine as it could possibly be for a radiologist to view studies in both of these what we call windows. So for us to change and manipulate the image from here to here is just a matter of 1 second basically to create this image or modify this image. And you can see that you're not seeing the bone as well in the soft tissue window, but you can see the tongue, you can see the floor of the mouth, and then you can see these abnormally rounded submandibular lymph nodes. But if you don't have a process in place where you're routinely and consistently evaluating for these types of findings, I promise you that they're sometimes there, and you just haven't recognized them, unfortunately.
Well, and just to be clear, you guys are, when you guys automatically upload our data, when someone becomes a client, like for me, every scan I'm taking now, you guys are reading, and they're automatically uploaded at the end of the business day. But you're getting our DICOM files. You're getting all of our raw data to import into your software that you know how to work with, that you can manipulate, very easily. You're not having to work, within the constraints of anyone's dental software. You're just taking that raw DICOM data, correct?
Yeah, that's exactly right. So it's called DentalRay Sync, and it just sits on, it's just an easy install that's on your scanner module computer. And then it will just bring over automatically into your dashboard every study that you take with your scanner. Anytime somebody presses the button, it goes into your dashboard. You can set it for us to review every single study by default and not have to worry about anything. And we'll interpret every study and send you a report and notify you if there's any critical important findings. But you can also dismiss a study if you have a repeat study, or there was motion on a study and you took 2 images on the same patient. You can go into your dashboard and just dismiss that study so that it doesn't go to a radiologist.
Thank you.
Yeah, let's go through. Here's an interesting. I know that we have a lot of people that are interested in TMJ and treating TMJ. It's an extremely interesting field, and this just shows you, I think, the worst TMJ degenerative change or sequelae of TMD that I've ever seen. So let's look at this patient. So these are 2 sagittal images, right, of the same patient. So on the right side of the patient and on the left side of the patient. And, in both of these cases, you have very severe temporomandibular joint degenerative changes, widening of the condylar fossa, marked joint space narrowing, and irregularity of that. You have that marked subchondral cortical bone irregularity. And on the right side, let's look right here. Behind the condylar fossa is the external auditory canal. So you can see that low density air going into the external auditory canal. On the left side, this is what our radiologist noticed, which I thought was really impressive. There's actually such severe TMJ degenerative change that it's fragmented that anterior wall of the external auditory canal, and it's displaced it posteriorly. So now you have bone and soft tissue completely occluding the external auditory canal. And this is the same patient in an axial image, right? So over here on the right side, you can see the patent external auditory canal. And on the left side, you can imagine that this person has a serious issue with conductive hearing loss because none of the, their external auditory canal is completely occluded. So I thought this was another great call out by our radiologist. And I think if you're just getting back to satisfaction of search, if you're just focused on the temporomandibular joint degenerative changes, you could potentially overlook a very serious problem that the patient could, benefit from. I mean, an ENT could easily go in and remove that little bone fragment and open up the external auditory canal.
So we're just being students now, Jacob. You just have to, we're soaking it in, because I know I've been guilty too, as I'm, in my novice eyes going through a CT, like slice by slice by slice, looking for those asymmetries. Then you go up a couple and you're like, oh, well, maybe it's there. And I was just at a different slice, or they're slightly asymmetrical. So, oh, we've just caught up with the airspace again. So now maybe there isn't any pathology there. And I think you're highlighting the critical detail of what, a radiologist is going to be able to see to discern asymmetries that are natural asymmetries that most humans have versus actual pathology that's present.
Yeah, it's really been fun. And again, it's been fun to take this interdisciplinary approach and to start interfacing with our colleagues and finding out, what do you need? We started DentalRay thinking, what we want to do is screen for everything else, right? And we want people to give people a big green check mark that says, hey, there's no unexpected or suspicious incidental findings. And now, now that we have that service provided, we now have some of our colleagues going back and asking us, hey, can you start to layer in all of this additional detail that I'd like for my specific practice? And I think Akshita referenced this earlier, but we're really proud. In fact, we're just rolling this out this week of this new reporting format where we have, because we're a nationwide company, we have a standardized reporting template, so that if you're getting a DentalRay study in Washington State or New Jersey, where the anatomic sections come in the same order. If you want to look at the airway, that it's right here in the same place every time, and that you're getting the same key images on every study. And this is something that I'm extremely excited about. We're just rolling out our temporomandibular joint degenerative change classification system, so that we have a standardized way of reporting and discussing this among dentists, physicians, ENTs, orthopedic surgeons, and also our volumetric airway analysis. And because we're building such a large data set, and we have these raw DICOM files, I'm really excited to start to collaborate with our colleagues in sleep medicine from the dental space, and also our medical sleep medicine colleagues, to start to correlate anatomic findings on cone beam CT with, for instance, like AHI on a sleep study, and start to see if we can pull out the threshold levels where these things become significant. And I'm really excited about rolling this new report structure out to our referring colleagues, but also starting, I think there's such a huge potential for education and research and getting this data published and having a standardized data set that we can then provide better care for our patients.
Dr. Brown, we actually have a live question. Would you be willing to entertain real quick,
Yes.
just based upon everything that we've heard tonight? Okay, hold on just a second. Would you be willing to ask your question, doctor?
Oh, he muted himself. What a novice.
The doctor's muted. We're going to start over again.
What a novice.
I'm such a rookie. Dr. Brown, how are you?
Very well, thank you.
Well, I've enjoyed your talk, but I have to ask the question now, after working with you and DentalRay and whatnot. What have you learned that's different about dental CTs compared to what you've seen in your hospital and physician settings? Kind of tell me where you guys were and what you've learned and where you're going.
Yeah, I mean, I think that the biggest thing that I've learned is, so obviously is putting ourselves in context. So when we're in the hospital and you have somebody with like it's a level 1 trauma, and they just got ejected from the vehicle, and they're doing a maxillofacial CT, and you have Lefort fractures, and it's just a big disaster. am I that focused? Is the ER physician really want me to be talking about the temporomandibular joint degenerative change in that context, or the little periapical lucency that I noticed? It's just not the right tailoring of the report to that physician. So
Sure.
I've loved getting feedback from all of you about what matters to you guys and what Akshita and all of my smarter colleagues are noticing everything as they go through the study. But we love getting feedback from you about what matters and what you guys want to see in our reporting. And so it's been super fun to start to tailor that and get that right level of reporting and detail and tailor it to the audience.
I've been really impressed. You guys now are picking up resorption, very minor areas of resorption on multiple teeth, and yeah, it's pretty awesome. I can say with confidence that there are dental interpretation services that I've sent to that don't pick those things up. And so from my perspective, being an endodontist, small field of view, you guys, I think, are doing an incredible job of differentiating yourself from level 1 trauma, but being able to be as focused and detail oriented as, hey, there's resorption on tooth number 22. You should probably tune into that. It's awesome.
Ryan, are you in Chad's study?
It kind of
Yes, he's right here.
That comes standard with every Texan house.
Apparently, I mean, if I see a Longhorn helmet back there, I know we're done.
Yeah.
No, I wouldn't stoop that low.
So for those of you that don't know, we have a really special friend of our group, Dr. Ryan Walsh. He's an endodontist locally here in Keller, Texas. He has also been very involved with DentalRay, and he was commenting tonight, and I texted him during the show. He asked a great question. I said, why don't you come on and ask it live? We've gone over. Honestly, I don't care. I mean, if anybody needs to leave, go. We're going to probably have to end pretty shortly here. But Ryan, thank you for being on and asking that.
Thanks so much, y'all.
This has been fantastic. Good to see you.
And by the way, Chad, just so everyone knows out there, I think the hierarchy is dentist, neuroradiologist, endodontist.
Oh, for sure.
Without a doubt.
Hey, Jeff, are you speaking in terms of financial? Or
obviously not. Quite obviously not.
No.
I think it's scholarship eligibility.
Yeah, it's scholarship eligibility.
And then endodontists don't need any scholarship.
That is right. That is the scholarship eligibility hierarchy.
That is the hierarchy.
I sure don't have as cool of big words to use as y'all and Jacob do. So I'll just stick with root canal.
Yeah.
Let's do something really fun now. I mean, we're over, but like I said,
this is green room happy hour.
This is green room happy hour. I think it's worth every minute of it. But
Dinks overtime.
Okay, we're going to have DentalRay back because there's a lot that we didn't get to, and I think maybe next time we'll focus it. But we've got 4 docs on here that use DentalRay. 4 docs that believe in DentalRay. So before we close, could we do just a real quick little round robin of what DentalRay has meant to each of our practices real quick? Is that okay? I know it's on the spot, but okay. Like anybody's going to say no, Chad, it's not okay. So Jeff didn't give me a thumbs up. So I'm going to start with Jeff. Jeff, what's DentalRay meant to your practice?
Swing. I mean, I told you before that, so having had this technology, CBCT, for 15 years, I kind of became good at reading it, but good at reading it from a dental perspective. So patient comes in with TMJ pain, and just as Jacob said, yeah, I can go in and I can find the TMJ pathology, but what about the skull base erosion or the external auditory canal, pathology that they're going to pick up? Or maybe some of the pain is cervically generated and I've totally missed the cervical spine. Or what if there's a parotid mass that's causing the pain that they're coming in? And Dr. Mehta said also one of the hardest things is the secondary diagnosis, right? It's like, just because they came in and they had TMJ pain and I found a probable reason doesn't mean that there's not other pathology on the scan. So while I thought I was pretty slick, and I even said to DentalRay, I don't know that I want you to read all of my scans because I've gotten pretty good at reading these. But no, I haven't. I still don't know what's going on. I don't know what's going on in this one, and I certainly don't know what's going on in everyone else's. There's so much there that I don't know, and isn't it nice to have that other set of eyes for when you lay your head on the pillow? Not only did I pick up what I'm used to looking at, but I made sure there was a secondary read to make sure that I wasn't missing something possibly bigger, like a Chiari defect or something crazy that could be contributing to the pain that people are coming in with. So my experience is like this, to me, is the single biggest game-changing technology we have seen in dentistry, is the ability for us to now use our instruments, these CBCT machines that take excellent scans, and not be afraid to take scans because of what we may be liable for. Do what we do, read what we know how to read, and then let the real experts look at all the other structures and say, hey, you know what? This might also be going on. So yes, I have them read every single scan now.
JB?
Well, I'd already alluded to part of it before, and that was just, you don't know what you don't know. And I had really scoped it down from a liability perspective to really get my field of view very small. And even still, I take a full CT on my particular unit, it doesn't look anything like y'all CT. It's still a smaller field of view. That being said, I was living in naivety, I think, thinking that I still could diagnose within that scope. You know, you buy the CT, you take their mandatory onboard training. They go through the 82 structures you need to be reviewing to sort of check it all off. And I bought into that philosophy, created my clinical note to do that, and started scoping through those. I know I've missed stuff. If there was pathology, then I certainly did miss it outside of the dental scope. But for me, the other piece of it that's been really huge is I used to spend, as Jacob kind of alluded, I spent a lot of time after hours, after patients had dismissed from the office, reviewing my CT scans to go through, writing my clinic notes, because I was the only one who, you know, my team writes a lot of my procedural notes because it's very repetitive over and over. We use this bond, we did this particular type of prosthetic. But CBCT, I am the end all be all for the interpretation. So I'm spending a lot of my own personal time combing through these CTs, probably inadequately, mind you. So wasting my time and not doing a great job simultaneously to ultimately comply with this liability piece and do what was best for the patient. The freedom that I get now of offloading that to a third-party vendor for interpretation, to get a report back, upload it into the chart, and have a good reflective report to go back to and reference at any given time. That's given me personal freedom back, time out of the office, of a lot more peace of mind that I have a comprehensive review of what I'm seeing. Even in a small field of view, it is comprehensive in review. And I can look at the patient very emphatically and say, there is no pathology to report. And I know that someone else is also checking behind me. And the last piece of that I'll say is I've used other interpretation services before. They were much more choppy and disjointed. They required a lot more of myself uploading and connecting all the pieces of their dashboards together to make all of that happen. For me, DentalRay has just been such a more seamless process. I don't have to think nearly as hard to get all of those pieces together. And I don't do auto upload because I have multiple doctors in our practice. So I'm using the service for my CTs. And even then I'm doing my own manual upload, and it's far easier to do that than some of the services I've used prior. Go ahead, Ryan, see if you can come behind that. I'll wait.
Dang, JB bringing heat. No, I think JB said it spot on. It's just seamless. The auto upload and not having to write a prescription and transpose, my notes from my chart and then go ahead and put that onto a web portal, I think is really, really big. Again, I'm with JB that, well, I do auto upload, but because I have multiple doctors in my practice, I just send them a list of the patients and or their, and I anonymize the patients and or send them their chart number, and they just go back and pull those up from our CT portal. So, I mean, or our CT hard drive rather. So that's about as easy as it gets. I don't have to sit there and type in name and date of birth, what I'm looking at, what I'd like you to look at. It's a thorough scan to begin with. And like I said before, they're noticing resorption on teeth. And to me, if you're at the level of detail where you're noticing invasive cervical resorption early on in the diagnostic process on a small field focus CT, that's fantastic. That's a confirmation of my diagnosis, as well as getting somebody else's eyes on it saying, hey, yes, I agree with you that there's a little something out of the ordinary here. Probably less really wild findings on a field focus CT, but nonetheless, every finding is a wild finding. So no, I appreciate it. It makes it seamless and easy. And it certainly saved me time and reviewing these, just like JB said, so I can spend that time with my patients educating. So kudos to DentalRay, loving it.
So I guess that brings it back to me. Thank you all.
Good luck, Chad.
Yeah, thanks. Yeah, thanks. So I'll
thanks everyone. It's been a great night. Have a good night.
Yeah.
First of all, I think it is probably time to go ahead and close the show, but I can tell you that this is not over. We will have you all back. Jacob, I'll start with you. Thank you very much for your time. Akshita, you said some words tonight that I didn't even have. My fingers weren't fast enough to type. Like, I was just sitting there going, what she said. Yep, that's exactly what I'm looking for.
That's why I have smart. That's why I have something smart.
I was like, you said stuff tonight that I did a lot of training. I never heard half of that crap. And I'm just thankful that you
I made them all up.
Those things.
None of that.
I want to take her to a party now and just get into a conversation and then say, have you met my friend? And then just like the words might drop it.
That's how I felt when I first met Jacob.
Yeah. It was amazing. Truly amazing. But I will say this to both of you, and I mean this. DentalRay has really changed the way that I look at things. It is such a blessing to walk in, talk to a patient. First of all, through your first several reads, I feel that I gathered a real good template for me to go through the CBCTs. So for your first several reads, I started going through the CBCTs outside of what I used to do. And I feel that I'm so much more knowledgeable. As time goes on, I have a feeling that I know exactly what you all are going to be looking for. And I know exactly what might be called out. But it's a blessing to be able to walk in there and share with the patient, hey, this is what I found on this radiograph. But I want you to understand that there's a heck of a lot more in this radiograph than your teeth and the supporting structures. And outside of those things, we send this off to a team of radiologists that are going to look at this with a fine-tooth comb and come back with a report. And if there's anything in that report, we'll get back to you. If there's not, then you're still welcome to a copy of the report. But the way that I look at it is no news is good news. I save a copy of that report in their chart, but I feel that I'm in tune enough to tell them whether there's something that's glaring or something that's not. Since I've been with DentalRay, I've missed one thing that I probably should have seen. And other than that, I feel that I'm pretty in tune with them. So you all have taught me a lot. So thank you. But you all have really changed my focus on CBCTs. I laughed yesterday. We posted something on our social media site that said, what's your biggest fear of CBCTs? And fear may not be the appropriate word, but it really is a big word. We're fearful of liability. We're fearful of what we may or may not see, or what we did or didn't see that we did or didn't catch. And I think that you all have really boosted us in that. So the biggest takeaway from this evening is that this is truly what it's about to be physicians and dentists and work together. And I think that, from the bottom of my heart, I thank you. I thank DentalRay for actually realizing that there's a gap there and helping us bridge that. Great people. somebody had asked about billing, and I'm just going to say, feel free to ask after the show, because we'll make sure that you get into the right hands. Somebody had asked about the charge for DentalRay. Ask after the show. We'll make sure that you get into the right hands for those answers. But
Chad, why don't we, we'll put a post up tomorrow about who to contact and
absolutely.
Yeah.
And there's also going to be a great deal from DentalRay. So let's do this again. Ryan, thanks for jumping on, buddy. Sorry.
Thanks for having me, y'all.
Great to see you, buddy. Get out of Chad's study.
Yeah.
Jacob and
thank you all. That's
Dr.
such,
Mehta, everybody at DentalRay, thank you.
That's such tremendous and gratifying feedback for us. It gives us a lot of reason to continue doing what we're doing. And thank you to our incredible technical and business development team at DentalRay. And thank you, Akshita, for joining us as well.
No, thank you all for letting me be a small part of tonight. This is incredible what you guys are doing. Thanks for doing your podcast and getting all this great information out there about the dental world. And thanks for letting me have a glass of wine with you today.
Exactly.
Yeah.
Anytime. You're welcome.
And
anytime.
I see a CE event of some type coming out of this, but we'll
Yes, sir.
talk about that. We'll work
Put
on
it out
that.
there.
Yeah.
That's what I'm feeling here.
Thank y'all. Thanks everybody for being a part of this. Thanks, DentalRay. This has been wonderful. It really is uplifting. Thank you all very much, and have a good evening.
Have a good
Thanks.
night.
Have a good night. And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.